Hi everyone, my name's Morgan Fernald and I am part of Group 26 and our project is on sleep physiology in the cardiopulmonary system. Together I worked on this project with Omar and Gabrielle. So what is sleep? Sleep is a state of partial unconsciousness with diminished skeletal muscle activity. There's depressed metabolism, but it's easily reversible. So it differentiates from a coma, which is a state of unconsciousness when a person cannot be awakened even by forceful stimuli. So whereas sleep, you can wake someone up by just saying their name, touching them, making a loud noise, someone wakes up. But a coma could actually be helpful in the case of like a traumatic brain injury where it gives the body time to rest and focus on the problems that need to get solved without having, the brain working and everything else. So how much should we sleep? Well, for everybody, it's different. For newborns, they should sleep about 17 hours a day, whereas adults should sleep about 6 to 8 hours a day. The amount of sleep needed seems to be dependent on body size because all mammals do need to sleep. However, things like cats and stuff, they sleep for 17 hours a day, which would be equivalent to a newborn, but adults, we don't need that much sleep. It is important for us to get enough sleep, though, for our bodies to recover, if we're exercising, have our muscles recover and be ready for the next day, as well as our brains if we're thinking a lot and doing a lot of stuff. Mental health is important, so sleep plays a factor in all of that. Sleep medicine is becoming more increasingly popular. There's more diagnostic and therapeutic services out there, which is driven by the heightened appreciation of sleep disorders in the general population. People are more open about their conditions and want to talk to each other just to spread awareness. It's also increased by the scientific research studies that are happening concerning the sleep and sleep disorders that are available. So there's more funding available for these kinds of things because they are being brought to life, and we're realizing that there is a problem with society's relationship to sleep. There's specialized sleep centers becoming more popular. They are laboratories and sleep centers, so they allow people to come in for sleep studies to see what's going on when they're sleeping, if they're not sleeping very well, if they stop breathing in their sleep apnea, things like that. There's diagnostic and therapeutic services to help people get the proper sleep that they need. Um, Sleep studies are known as polysomnography or an epic, which is a recorded measurement of time during a sleep study of multiple physiological variables that can be used to identify different phases of sleep and, more importantly, the sleep disorders that are going on. So, things to identify this would be an electroencephalogram, an EEG, which measures the electrophysiological changes in the brain. There's an electrooculogram, which monitors the movement of your eyes as you sleep. The electromyogram, which measures the muscle activity that's going on in your body. And then the end-tidal CO2 can kind of offer some insight into what's going on with your breathing as you're sleeping. Other features that are monitored in these kind of tests would be the presence or absence of snoring, nasal and oral airflow, chest movement, your abdomen movement, the SAO, and then the electrocardiogram. So, sleep studies are available for neonates, infants, children, and adults, obviously. But some different markers are used sometimes. So, there'll be like the end-tidal CO2 that I mentioned earlier, which monitors the airflow as a surrogate. And then there's the thermistors, which sense a change in temperature. Then there's these different kinds of EEG waves that we're going to go over because we are going to see these in action in a little while. So, we have beta waves, which are low voltage amplitude. They're known as the busy waves of the brain, and they're recorded when a patient's alert with their eyes open. And it can also be seen during N1 sleep, which is the beginning of the sleep. We also have alpha waves, which have a relatively high voltage or amplitude frequency. They're known as the relaxed waves of the brain. When a person's awake, they're usually present, and as they're like becoming more sleepy, getting drowsy, going into that N1 state that we're going to talk about. They're also found when a person wakes up during their sleep. like just sudden periods of being awake. There's theta waves, so they're low frequency with low amplitudes. They're known as like the drowsy waves. You'll see those during REM sleep and then during N2 sleep. They're present in the stage 1 sleep. We have delta waves, which are primarily seen during the N3 stage of sleep. Those are like when you're in your deep sleep, not e the person's not easily to be woken up. Then we have K complexes, which are intermittent high amplitude biphastic waves of 0.5 second durations in the start of the N2 sleep. So, as we see on here, they're represented by the green bars. And they can be seen in N3 stage of sleep sometimes, and they're usually co-paired with the sleep spindles. So sleep spindles are the sudden bursts of activity. They'll be seen in the N2 sleep, and they don't really show up during the REM sleep. We have sawtooth waves, which are jagged waves that you'll see. They're usually present during the REM sleep, and they're not part of the criteria of REM sleep, but it's basically an indication of the REM sleep happening. Then we have the vertex waves, which are going to be uh, the sharp negative waves. They're usually seen at the end of stage N1. Um, all right. So we have two major types of sleep. We have that uh, non-rapid eye movement sleep, which would be known as the non-REM or the NREM. And then we have the rapid eye movement, the REM sleep that I had mentioned earlier. So as we start to go to sleep, there's the eyes open wake stage, which is also known as the stage W. It appears similar to the REM sleep, and the EEG has beta waves with a high frequency, low amplitude activity, and then the sawtooth waves that I mentioned earlier, as we can see on this slide. The EOG is low frequency and variable, and the EMG is relatively high. Then we have the eyes closed wake state, which is considered like a drowsy period, prominent alpha waves. The EOG is tracing is characterized by the slow rolling eye movement that's going on, and then the EMG is relatively high. So we can see down here, all of this is present. Um, and yeah, so they're starting to get into their sleep. Then we have the non-REM sleep. It's known as N sleep. There's three stages. We have N1, N2, and N3. It accounts for the 70 to 80% of the sleep in an average adult. So the N1 sleep is known as the transition stage between drowsiness and sleep. Oftentimes the person is going to have like a floating or drifting sensation. There's also a phenomenon called hypnic myoclonus, which is like the sudden mo muscle contraction. If you've ever watched someone fall asleep, you'll see them like jolt or all their muscles just contract, and you're like, oh, what's going on? And they're just falling asleep. It usually takes 10 to 12 minutes that a person's in this stage, and it's very light sleep. So the alpha waves show that the brain is calm and relaxed. The EOG has slow rolling eye movements. Nocturnal dipping is another phenomenon. It's when the heart rate and blood pressure slightly decrease as a person is falling asleep. And so if you wake up a person that's in this stage, they might just say, "Oh, I wasn't asleep," you know. We've all been there, we've all seen it happen. Um, so we can see over here, you'll see the beta, theta, alpha waves, and the vertex waves present on the EEG. The eyes rolling for the EOG, those are present on there. The O2 is good, and the pulse is pretty normal. Then we have the N2 sleep here. So it's a relatively light sleep, but it's harder to wake up than the N1. So you're getting deeper into your sleep. It's about 40 to 50% of your sleep. Some snoring may occur. The EEG is more irregular, as we're seeing over here on the right. Theta waves are more present with some sleep spindles and K complexes, which we talked about before. And they are pointed out on this over here on the right. You'll see the K complexes in green and the sleep spindles in the pink highlighted. And then we have vertex waves that are in the yellow. The EOG has slow eye movements or an absence of slow eye movements. So we're not really seeing much going on with the eyes. Nothing really major. The EMG also shows low electrical activity. Like we mentioned before, the blood pressure, the heart rate, and the temperature is continuing to decrease. A person awakened from this state may say, "Oh, I was just daydreaming," or, I'm thinking, I got a lot in my head. We've all experienced that as well. So now we're getting into the deeper sleep. So this would be like N3. There's two categories. So we have the slow wave sleep, and then we have the deep sleep. So the slow wave sleep starts 20 to 25 minutes after the start of N1. There's 20 to 50% of the EEG is high amplitude, slow frequency delta waves with sleep spindles, and the K complexes may also be there. The EOG has little to no eye movement. The EMG activity is low. And there's still the decreased heart rate, blood pressure, respiratory rate, body temperature, oxygen consumption. There is some light dreaming going on, and the person is harder to wake. So for deep sleep, 50% of the EEG is going to be those delta waves. The EOG has no eye movement. The EMG has little to no activity. The sleeper is relaxed with minimal movement, and it's the hardest stage for them to awaken out of right now. There's night terrors that may be happening, bedwetting, and sleepwalking in this state. So a person's really getting into their dreams at this point. Uh, these are the delta waves that are going on at the top. We can see they're like highlighted in this orange. The respiratory and the heart rate are generally decreased to like 20 to 30% below their normal levels as they are awake. Yeah. And that's all I have for you guys. Omar and Gabrielle will finish up the rest.
First REM or paradoxic sleep period lasts around 5 to 30 minutes and usually occurs 70 to 90 minutes after falling asleep. Most dreams occur during REM and consist of vivid content, full color, sounds, bizarre settings, and even a sense of paralysis. EEG activity, which you can see on the diagram to the right, shows sawtooth waves, which is shown in the brown bar, and sometimes even some alpha waves, which are shown in purple. The EOG shows rapid eye movement, and the EMG records low electrical activity and the paralysis of skeletal muscles. During REM, the brain metabolism and respiratory rate increases, though the respiratory rate is irregular and shallow. The heart rate is inconsistent, but the heart rate and blood pressure do increase. And again, rapid eye movement does occur. The time needed to fall asleep is known as sleep latency, and it usually takes around 10 to 30 minutes on average for a person to fall asleep. It's generally accepted that a sleep latency period less than 5 minutes indicates excessive sleepiness, while a period of over 30 minutes is indicative of lack of sleepiness. And this can be due to emotional stress, disturbances in the surrounding environment, medication or illness, and pain. A full sleep cycle consists of multiple stages, beginning with N1. It then moves towards N2, then N3, which consists of slow wave and deep sleep, before eventually returning to stage N2. From N2, the sleeper can go into REM sleep. Though this is the conclusion of the first sleep cycle, the sleeper will move from REM to N2 to start a new sleep cycle. Each cycle lasts about 90 to 110 minutes. For example, N1 to N3 takes 30 minutes, remaining in deep stage N3 for 20 to 30 minutes, then moving to slow wave sleep for 20 to 30 minutes before going to stage N2 and REM, which lasts anywhere from 5 to 30 minutes. Throughout the night, REM sleep increases in duration while deep sleep N3 stage decreases. Older adults can even bypass REM sleep altogether and awaken, which, as you get older, is bound to happen as the number and duration of nocturnal awakenings increase with age. Sleep is obviously essential for human functioning. A lack of sleep affects our physical and mental health as it can lead to difficulty concentrating, impaired memory, and physical performance, and can create an inability to perform basic mental tasks. It can also lead to depression, paranoia, hallucinations, and even mood swings. First, sleep functions as a period of restoration for the body. Non-REM sleep promotes physical growth and healing as it is involved in the release of growth hormone during slow wave sleep. Body cells also have increased production while there is a reduced protein breakdown during sleep. REM sleep also helps restore important brain processes like attention span, learning and memory, social skills, and emotional healing. Sleep also functions as an energy conserver. While sleep energy consumption is decreased due to the fact that metabolic rates decrease 5 to 25% during non-REM slow wave sleep. As one ages, slow wave sleep declines, which is believed to be due to the fact that energy requirements and the need to conserve energy also decreases. Circadian rhythms are biologic rhythms that occur at regular intervals of 24 hours. When a person's biologic clock responds to a good sleep-wake pattern, they are in what's known as circadian synchronization. The number one problem affecting people today is sleep debt. Essentially, this is a person's specific sleep requirement or the amount needed to maintain constant functioning. Any amount less than the requirement is considered lost sleep. And sleep debt is the total of all nights of lost sleep. Sleep patterns are established within the first few months of life and continue throughout life with a gradual decrease alongside advancing age. For newborns and infants, they require about 16 to 17 hours of sleep per day, usually divided into 7 fairly equal sleep periods and waking up about every 3 to 4 hours. Infants spend about 50% of their time in non-REM sleep and the other 50% in REM, where they will experience twitching, coughing, and gurgles. By month 4, infants will be able to sleep throughout the night with short naps throughout the day, and by 1 year, they will sleep around 14 hours a day, only needing 1 to 2 naps throughout the day. For toddler and preschoolers, total sleep time decreases from 14 hours at age 2 to 12 hours a day by age 5. This is usually due to the elimination of the afternoon nap, although preschoolers still do require an afternoon nap. REM sleep also decreases to about 30%, with slow wave sleep being high. In children and adolescents, they are required to sleep roughly 8 to 12 hours a day. And once they reach age 12, however, less sleep is required, with adolescents needing only 8 to 10 hours a day. REM sleep also decreases to 20% for both children and adolescents. Here you can see in the chart roughly how often they wake up and how long they stay within each stage. In young adults, they require only 6 to 8 hours of sleep per day, with only 20% of that being in REM. As you can see in the graph, time spent during N3 progressively decreases while the number of sleep arousals increases. Finally, older adults also only require 6 to 8 hours of sleep per day, although they spend 20 to 25% in REM sleep. At this age, stage 3 is significantly reduced or even absent. It also takes a longer time to fall asleep and they awaken much more frequently, which is shown in the chart. They also can take longer to fall back asleep after waking, can feel drowsy during the day, and will take longer to adjust to any changes in their sleep schedule. So as you can see, there are many factors that can not only influence the sleep quality, but also your total time asleep. Age is a major factor, as we've discussed, with more frequent sleep arousals. I also have mentioned that aspects like illness, emotional stress, medication, and environmental disturbances all work to disturb a person's normal sleep cycle.
Welcome to the third and final section of our presentation. So I'm going to be going over the common sleep disorders. The first one is insomnia, which is the most common sleep disorder, and it's characterized by the inability to fall asleep or remain asleep. So there's different types of insomnia. One is transient, which lasts less than a week, or short-term insomnia, which lasts between 1 to 3 weeks. And there's also chronic insomnia, which lasts longer than 3 weeks and is persistent maybe over a lifetime. There's also hypersomnia, which is kind of the opposite. It's periods of deep, long sleep of abnormal duration, whereas maybe it's over 8 hours, it's extended 11, 12 hours, and that's consistent, which is pretty abnormal. And it's caused by psychological rather than physical factors or associated with a state of confusion upon awakening. Another one is narcolepsy, which is a hereditary disorder, and it's characterized by sudden sleep attacks that occur throughout the day, where you'll just randomly be talking and you'll fall asleep out of nowhere. And it lasts between several seconds to 30 minutes, classified as hypersomnia, which is sleep of abnormal duration. And individuals who are narcoleptic may also experience cataplexy, which is loss of muscle due to disordered sleeping because your body needs to rest at night in order to be able to rebuild muscle. So if it's sleeping sporadically throughout the day, you're not getting that adequate rest. And there's also sleep apnea, which is cessation of breathing during sleep, which is funny because as you can see, I'm wearing the little nose tape. And what that does is it helps me breathe better, opens up my nasal airways better to allow for more airflow during sleep. And this is one of the treatments that people may use for sleep apnea. So there's obstructive sleep apnea, which is the cessation of airflow through the nose and mouth with persistent diaphragmatic and intercostal muscle activity, which means that your nasal airflow and your mouth are what's impacted, but your diaphragm and your intercostal muscles, your body is still working to be able to inspire and expire. It's just that the nasal cavity and the mouth may be blocked off, which might be the reason why some people start snoring. And it's characterized by loud snoring followed by silence with struggle breathing. So there's periods of the night where you snore really loudly and then it'll stop and you'll be silent. But once you're silent, that's you being unable to breathe because for some people, their tongue will fall back into their mouth. So that was obstructive sleep apnea. There's central sleep apnea, which is cessation of airflow with no respiratory effort. And that's when the respiratory system is also shut down, along with the lack of airflow through the nose and the mouth. And that one's more serious. So mixed sleep apnea is where it starts off initially central and then it becomes obstructive later on into the night. So this is a diagram of a sleep study done, and it's a patient asleep during their sleep study where they have this little mask attached to their nose so they can track everything, track their breathing. And this is done so that they can see which abnormal sleep patterns the patient has, and then they can prescribe them the proper treatment. So B is the obstructive airway during inspiration, and it shows the lack of airflow going inside the nose and what causes, difficulty breathing at night. And C is the therapeutic effects of positive pressure from the CPAP mask. So what the CPAP mask will do is it actually forces air into the nose. It applies positive pressure, whereas normally breathing is negative pressure based on what's it called? On gradients, which there's a lack of volume, which means increased pressure, which pushes air out, and then the opposite, which allows air to come inside your system. So this one's positive pressure, whereas the body doesn't need to work as hard, but the air is actually being forced you know, into your body. Whereas over here, there's a bunch of negative pressure. So these are the risk factors associated with apnea. For obstructive, being a male, actually, there's some overlap between the two. So being of the male gender causes more of a risk for having apnea. More males are likely to develop sleep apnea, whether it's obstructive or central. Obesity is also a factor, in specifically obstructive. Increasing age, so over 65 years old, they typically struggle with it. Hypertension, having a large neck, chronic nasal congestion, these are all obstructive risk factors. Whereas for central, yes, the male gender, age, but it also takes into account heart disorders, such as, or one of them typically being AFib, strokes, brain tumors, high altitude, and opioids. And these might be some of the causes why you might have difficulty breathing through the mouth and the nose, but also difficulty with, the respiratory structures. So, periodic limb movement disorder, PLMD for short, it's characterized by repetitive stereotyped movement of the leg muscles during sleep. Whereas you'll be trying to sleep and you feel your leg just fidgeting all of a sudden. And it's a rhythmic pattern. So it follows a structure, it follows a certain cadence. And it occurs during non-REM sleep where you're not fully deep into the sleep. And the incidence or the occurrence of it increases with age. So the older you get, the more likely you are to have it occur. And restless leg syndrome, or RLS for short, is characterized by intense, unpleasant feelings occurring between the knees and the ankles. So it's essentially a tingling or an itching or a burning. It's just an uncomfortable sensation in the legs that persists throughout the day. And what it ends up causing is it causes constant leg movement throughout the night because the body feels that unpleasant feeling and it's trying to rid it. So it causes that movement, causes that friction to try and rid it. So there'll be constant leg movement throughout the day and your body's essentially awake at night, so you'll have insomnia. And these are typical therapeutic interventions to manage sleep apnea, and they differ between obstructive and central. So there's, of course, mechanical ventilation and continuous positive airway pressure, the CPAP machine, which is a therapeutic, a treatment for obstructive sleep apnea, which has 100% efficiency and success rate. But for central sleep apnea, it's only fairly effective. It's not going to completely, you know, erase that. Mechanical ventilation, it only helps short term with obstructive sleep apnea, and same thing with central. Negative pressure ventilation, which is essentially the opposite of the CPAP, is contraindicated. It's against the obstructive sleep apnea, whereas it's therapeutic for central. And these are other, therapeutic interventions that they'll use. And so what it looks like is either something will help for obstructive and not help for central, or it can also help for one and it can be counterproductive for the other. So there's a lot of, I guess, thought that needs to go into it to ensure that, you find the correct type of sleep apnea that the patient is experiencing, and then you can offer them the correct treatment so that it doesn't obstruct the other. So now we're going to go over normal cardiopulmonary physiology during sleep, what should happen normally. And the way this is brought about, and this happens over many different body systems, the musculoskeletal system, the digestive system, your gonads, everything. So, and what causes this is the autonomic nervous system, which is, it's involuntary. So it just happens. It's a passive process throughout your body. You have no control over it, especially while you're asleep. And specifically, it's innervated through the parasympathetic nervous system, which everybody or most people should know as rest and digest, whereas the sympathetic is fight or flight, sorry. So fight or flight for the sympathetic and rest and digest for the parasympathetic, where the parasympathetic is involved in sleep and regulating the body system to cause changes depending on what form of sleep you're experiencing. And so we're going to start off with the musculoskeletal system. So muscle tone is at its lowest during REM sleep. Muscle tone essentially meaning the amount of effort exerted by the muscle. And that's because muscle tone decreases while you enter REM sleep so that your body can go and break down and heal the broken down muscles. So essentially at that point, the body is paralyzed and the muscles don't move. For example, the genioglossus muscle, which pulls the tongue down and forward. And like I said earlier, the tongue falling back causes obstructive sleep apnea, and that's because the genioglossus muscle, which normally pulls the tongue down and keeps it from falling into the back of your throat, is inactivated. And so it causes the tongue to fall back. Malfunctioning REM causes sleep thrashing because the muscles are still awake. Some people, they don't fully fall asleep, and so their body is technically still awake while their mind is asleep. And so they'll start moving around. And decrease in that increase in muscle tone where your body's not fully rested and your muscles aren't fully rested, you'll wake up feeling much more tired and your body feels, you feel really lethargic because your body didn't get that adequate sleep at night. And now thermal regulation. During non-REM sleep, the body temperature falls by 1 degree Celsius to 2 degrees Celsius. Whereas during REM sleep, the body temperature increases variably, depending on how cold it is in your room or how hot or what your body needs during the sleep, during REM sleep. Renal function. So renal perfusion, which is blood flow, is decreased during REM sleep so that there's decreased urine production. So some people don't have to use, the bathroom at night. It decreases renal perfusion, so there's not as much flowing. And urine production decreases, like I said, during REM sleep. So during both. And in genital function, there's little to no change in genital function during non-REM sleep, but in REM sleep is when the men is like they're associated with penile tumescence, which is an erection, and the sleep-related erections occur as a result of parasympathetic stimulation. And what that causes is vasodilation, so that there's blood flowing throughout the body to remove toxins and to help with digestion and metabolizing all the food you've eaten throughout the day. And so when the blood is vasodilating, it causes you know, that erection. And GI function, the changes brought about by increased parasympathetic nervous system, the circadian rhythm, and central nervous system activity. That's what causes, increase or decrease. So like I said, what happens in the GI system is that salivation and esophageal motility are decreased during sleep, so that your body doesn't need to produce the saliva, which helps with digesting enzymes that you're eating throughout the day, and esophageal motility because you're not eating any food, so there's nothing that has to be sent down through the esophagus, through peristalsis. And gastric acid secretions follow circadian rhythm and peak between 10 p.m. to 2 a.m. So that's to help your body digest the food. And it peaks during 10 p.m. to 2 a.m. So a lot of people who don't sleep during specific times at night and their circadian rhythms are thrown off, they struggle with digestive issues. So endocrine function, plasma growth hormone peaks at 90 minutes after the onset of sleep. So in order to grow, your muscle strengthen and your bones harden, you need growth hormone, and that peaks around 90 minutes after the onset of sleep. So people who have sporadic sleep issues, they might struggle with their growth hormone levels. And patients with sleep apnea show inverse correlation between sleep and plasma GH. See? So because they're not getting the proper amount of sleep or their body's not, they're not breathing properly, it shows an increase. So the more someone has sleep apnea, the less they have growth hormone in their blood flow. So adrenocorticotropic hormone and cortisol peak between 4 to 8 a.m. So a lot of these hormones, they follow a circadian rhythm. So they peak at certain times during the night, which is why the body, there's different hormones that cause sleepiness, and that might be caused by temperature or the lack of light. So once it gets dark, your body feels tired because that's the body's automatic way of telling you, okay, hey, it's tired, go to sleep. Because all these hormonal systems, they peak at certain times of the night. Your body is a system that functions at different times, and you need to be able to optimize that to your best in order to, have optimal levels of these hormones and keep your body regulated. So cardiovascular function during sleep. During non-REM sleep, the vagal nerve activity maintains autonomic stability. So the heart rate and the blood pressure, it'll show like dipping patterns, but it'll be maintained. And cardiac health indicator, which is normal inspiration briefly raises the blood heart rate and blood pressure, while expiration lowers them. So it's, highs and lows to keep the heart regulated. During REM sleep, however, the heart rate becomes highly variable with fluctuations up to a 35% increase. So it'll have much more highs and lows during your deep REM sleep, which is why it kind of is associated with some people think that, they die when they sleep because their heart has these patterns where it's changing completely in the way it beats normally. So it might seem like the patient is out. And so sleep dysrhythmias during non-REM, the vagal activity lowers the heart rate and blood pressure. And the cardiac risk is the autonomic surges raise heart rate and blood pressure, right? Like I said, the increase and decrease dip. And there's oxygen imbalance in the REM, whereas increased sympathetic tone, right? The muscle tone lowers oxygen supply and causes vasoconstriction. It may trigger angina pectoris or breathing issues in heart failure. For cerebral blood flow, non-REM sleep, cerebral blood flow decreases. And during REM sleep, cerebral and spinal cord blood flow increases along with cerebral metabolic rate. That's when you're dreaming so that more blood goes into your brain and there's more activity going on. And post-sleep wakefulness, the cerebral blood flow is lower than during pre-sleep wakefulness. Now, the respiratory physiology, which we've been talking about for most of this chapter, During non-REM sleep, the respiratory rate and minute ventilation decrease due to reduced metabolic rate and lower medullary sensitivity to carbon dioxide and oxygen changes. See, it's oxygen and carbon dioxide regulating the blood and acidosis or alkalosis. So during REM sleep, breathing becomes irregular with fluctuating respiratory rates, likely due to brainstem neuron activity because there's so much going on in your brain at the time. There's so much blood being passed into the brain that the breathing rate fluctuates. Overall, though, chemoreceptor sensitivity and airway muscle tone are reduced during sleep, affecting respiratory response. And this is a graph that shows the normal ventilatory response to changing partial pressures of carbon dioxide during non-REM and REM sleep. So during stage N1, that's non-REM, obviously, it's the ventilation, it peaks at a lower partial pressure of carbon dioxide. And then stage two, it starts to get lower. The ventilation rate decreases all the way to the bottom, and then it doesn't really reach in either of these, especially during REM sleep. It doesn't ever reach that peak that it does during the first initial stage of sleep.